Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And here we are again doing another Q&A.
Another Q&A, good.
We've got lots of questions.
Yeah.
And then after this, I think we might need you to put more questions in. I think we've done them all.
We're nearly out. We're nearly out of questions, everybody.
Yeah.
Keep them coming because these are good episodes.
Yeah, they really are. So as is what we like to do, and that is to get straight into it. So here's our first one, Pat.
Hello. My question is about my luteal phase. So for context with my first pregnancy, my partner and I were trying for about 2 years, but 9 months of that was very militant trying. I'd been referred for ovulation induction, but we did manage to get pregnant just before I started taking the medications for that. So got pregnant naturally. I have been diagnosed with endometriosis and polycystic ovary syndrome. So my cycles do kind of jump around in length. But what I have found through doing ovulation testing and tracking my cycle quite rigorously this time round is that my luteal phase tends to be about 9 days long. I'm just wondering if that could be a major impact into why I'm having trouble conceiving. If there's anything that I can do to lengthen that luteal phase, and basically just, any sort of things that I can be doing to give myself the best chances for conceiving a second time round.
There we go. Social media says a lot about luteal phase.
Yeah.
And no wonder people start asking about it.
Yeah, you do. You see a lot about luteal phase, but you don't see nearly enough about regularity of ovulation, in my opinion. So it sounds like this woman who's got in contact with us, which is fantastic, and I love this question. I also love the idea of militant.
Oh my God, I was going to say that too.
So
yeah. Here I am, I'm imagining like these 2 soldiers. Okay, off we go to the bed.
Yeah.
And sorry that people have to do that.
Orders have come through from HQ, and it's time to militantly try. I think that
I get that though. Like if you've been trying for 2 years, and then they're like, no, we've got to get have this well-timed regular sex. Yeah, it's tricky.
Yep. So the overall picture of someone who's got a diagnosis of to use the old term PCOS, it's and cycle irregularity. To me, it seems more likely that the problem is not luteal phase length, between ovulation and the period starting again, so much as it is regularity of ovulation. And the regularity of ovulation, clearly she's ovulated at least once because she got pregnant once before without specific intervention. But this is a numbers game, and we want to ovulate every 4 weeks, and you get 13 rolls of the dice per year. Of course your number will come up eventually if there's nothing else wrong. So rather than focusing on the length of the luteal phase, I think a better idea would be to make sure we're ovulating every single month. Some people have a problem with the progesterone levels in the second half of the cycle. Typical situation is where the embryos come in an IVF situation from the freezer and it's been thawed out and put in. So the woman hasn't ovulated at all, and so there's a potential of where's the progesterone going to come from in those early cycles. But that's really an IVF thing. And for this couple, I think they should be concentrating really on making sure that they're ovulating every single 4 weeks or as close as we can to that, to give themselves more chances. But when we combine the fact that there's a known ovulatory issue, a potential luteal phase issue, and endometriosis, this is somebody with a significant risk to their fertility and a real chance of not achieving their desired family size unless they have some expert intervention. So I think that combo is a significant one, and that someone in this situation should be definitely seeking expert advice from a reproductive service.
She didn't say her age, but let's say, she started when they were 32, 33, and then they spent 2 years trying to get the first baby. They might not have those extra 2 years to see if they can conceive naturally.
That's right, and that's why, in a reproductive or fertility consultation, the first thing we ask is how old are you, and the second thing we ask is how many babies do you want? How many times do we have to get this magic trick going for you to have the family size before your fertility naturally runs out?
And I wonder why someone has reluctance, and not saying that this caller had reluctance, towards trying ovulation induction. Are there any sort of risks or side effects that would prevent somebody from wanting to try ovulation induction?
No, that's a good point, isn't it? I don't think that they've got anything to fear from ovulation induction. It's just taking some tablets towards the start of the cycle to make sure that to help the ovary pick an egg, mature it up, and pop it out. And done carefully with ultrasound surveillance, we can keep the multiple birth rate to a minimum, and it's safe and effective. A lot of people who wind up towards the end of their fertile years, still wanting a few more babies and turning towards IVF, have probably had a ovulation problem for a lot of their reproductive life. And if they had embraced ovulation induction earlier in their fertility journey, they may not have wound up needing IVF at the end. The IVFs come in at the end because they're running out of time.
Such good points. All right, well, I hope that has helped that caller.
Yeah, I think that that the combination of 3 or 4 separate problems, that rings alarm bells for me. We don't know, perhaps they're under a fertility service already, but let's say they're not. I think it's time for that to be really top of priority. See, it's awesome that she got pregnant that one time, but people with severe fertility problems will get pregnant through good luck alone.
It just took her 26 months.
Occasionally.
No, more.
So
24 months. Yeah.
So that's a problem in itself. She's sort of grateful for that one pregnancy, but mathematically it should have happened much earlier. Yeah. So there is an issue here, and we need to factor in. If she's in her mid-20s and only wants one more baby, then she could just probably wait and rely on luck. But if she's in her mid-30s and wants 2 more babies, no, the numbers will catch up with you. So time for some action.
Great. All right. Now, I want to say to people, we are getting a lot of questions, and I love them, and about forever chemicals, EDCs, sunscreen, makeup, shampoo, getting your hair dyed. And we haven't broached that yet because we haven't found the expert to help us with that.
We need someone who really knows what they're talking about that. Yeah.
So we are researching, and we are trying. And if we have an expert listening to this and say who's trying to get pregnant but wants the pregnancy information but has expert information, get in touch with us, because it's top of mind for people, and we're not ignoring it.
Yeah.
We just, we always want to bring you the best information. And there is a lot of fear mongering. There's a lot of opinion out there about whether you should be, ditching all your plastic containers and not getting your hair dyed. But we want to bring to you something that's pretty robust.
Absolutely.
So we'll get there.
Yeah. We want to be as sort of scientific as possible about that, because I really don't like the idea of people latching on to the idea that their sunscreen is causing their infertility and spending any time at all on that when they're clearly not the chief cause.
Yeah.
Even if there is an effect, who knows? But if that same person has endometriosis, or their partner's got no sperms, or they're not ovulating, that's where the payoff's going to be.
Yeah, and also weighing up the risks and benefits. I'm pretty sure that there's a massive benefit from putting sunscreen on than not. But
100%.
Yeah, we'll get that expert in.
Good.
All right, let's move on to this caller.
Hi guys, I love your podcast. I've listened to every episode now to prepare myself for my first pregnancy. I'm currently 29 weeks pregnant and I'm 33 years old. We conceived this baby within 3 months of trying and have had no complications so far. On my 20-week scan, I was found to have an extra lobe on my placenta, so essentially an extra little bit that's attached to the main placenta. The position of my placenta is anterior and wraps around the side. It's quite high and not near the cervix. I'd love to know more about how this could affect me during the late stages in pregnancy and birth. My research says I could have a slightly higher chance of hemorrhage, so would it be wise to have an active third stage of labour? Is it possible that the lobe could detach during contractions and cause fetal stress? And what happens if the placenta delivers but then leaves the lobe behind? Thank you.
Thank you for listening to every one of our podcasts.
That's awesome. Well done.
And it isn't a flex to say that you got pregnant within 3 months of trying. It is hard to hear that for people that perhaps have spent 3 years of trying. But it's also good to help people know there is that chance.
Yep.
You
That's
can.
body working normally.
Yeah. Good.
So
So many things you need to answer here.
Yeah, extraplacental lobes is just an interesting area. There are a number of different variations in the placental anatomy, and there's a thing called a succenturiate lobe, which is a sort of an extra.
Hang on, say that again.
Succenturiate lobe.
Ooh.
I don't know what that word really means. I mean, I know what it means, but I don't know where the word comes from.
It would be bad if it was somebody's surname. And first name, Mr. Suction Turian.
No, it's not named after someone.
Oh, good.
All right, so that it just means that the placenta is sitting there as like a dinner plate, and then there's a little gap, and then there's an extra little bit, like a little saucer next to the dinner plate, and that is part of the placenta, but it's separate to the rest of the placenta. And these are only really significant if there's vessels running between the two, and in particular if the vessel that runs between the two crosses the cervix. So that's a thing called a vasoprevia, and theoretically you could break your waters and start to contract, and then the cervix dilating could tear the vessels that connect the two. And that's a ruptured vasoprevia, which is a very severe, very serious pregnancy complication because that's fetal blood that's inside there, and all the blood can run out of the baby. So that's a serious situation where we would advise birth by caesarean section. Often, if there's a little extra lobe, but the vessels connecting the two aren't crossing the cervix, then that doesn't really matter. That pretty much behaves like a normal placenta. And given that the location of the placenta that the caller describes, that's probably the setup that she's got. And they'll be looking very carefully on expert ultrasounds to make sure that there's no abnormal vessels connecting those two bits of the placenta that cross the cervix. Apart from that, you just have to make sure it's all there. So if you've got a known succenturiate lobe, it's not like it's sitting over there all by itself. It's still attached to the membranes. So when all of the membranes and the placenta come out, you should be able to do the usual thing of spreading the placenta out on a tabletop and examining it. And you'll see the main bit of the placenta, and then a few centimetres away, still attached to the sac, you'll see the extra little bit. And as long as that's all there, it's all there. We're fine. Theoretically, any of the placenta can get left behind at a birth, and I guess the extra lobe could get left behind as well. And in that situation, the uterus can't contract properly. The woman would be at risk of a postpartum hemorrhage, and so we would want to be seriously sure that we had got it all out. Yeah. If we're convinced that some's left behind, then that's usually a trip to operating theatre situation, off to sleep for a moment, and we put a hand in and scoop out the placenta that's left behind.
That sounds dreadful.
Well, yeah.
You're anaesthetized.
Asleep,
so,
yeah. So the idea is just one of the most important jobs at a birth is usually a midwifery job, is to examine the placenta carefully and make sure that it's all there.
And what about her question about active third stage management?
Oh, well, I think everyone should
have that.
So postpartum hemorrhages are better prevented than treated. I think this is a little bit poorly understood, but out there, we do a very, very good job managing hemorrhages. They're not rare; they're common. A significant hemorrhage happens every single day in a busy obstetric hospital, and we're just very, very good at managing it. But we would rather prevent them than have to fix them. And if you prevent them, everything goes better. So I would recommend active management of the third stage for everybody. Now, if somebody doesn't want that, that's okay. We would tend to counsel people about the risks of doing that, and then perhaps there would be some people who we would be particularly concerned if they didn't want preventative management in the third stage, and that might be somebody with a higher risk of postpartum hemorrhage, so a placental abnormality, a previous postpartum hemorrhage, super extra big baby, and in this situation, the risk of postpartum hemorrhage from this extra lobe, it would be a small additional risk, but I would still recommend that someone with this anatomy had a active management at the third stage.
Of your patients that come in and say, I don't want an active third stage management, what do you think they think are the benefits of not having that stage?
I think there aren't any significant risks to the active management of the third stage. So it seems like a good idea to prevent a postpartum hemorrhage rather than having one and then trying to fix it. So I think people are either trying to keep the birth as natural and unmedicated as possible, which is a sentiment that I understand. It's just that Mother Nature can be a bit cruel, and the complication rates for pregnancies are a real everyday challenge. Some of the other reasons that people give to avoid active management of the third stage don't stand up to scrutiny. So, like, it interferes with breastfeeding, or it does this or it does that, and those things just aren't true.
I wonder whether it's something that women feel so out of control in their labour and birth that they feel that is something they can make a choice over.
Oh, yeah. Well, we've discussed that elsewhere, haven't we? That in the podcast, that's what I think is really behind it. Because we've a number of different times on this podcast have looked into why would somebody make a decision that has been conclusively proven to be less safe, and the answer might be that safety is not the be all and end all, and sometimes people are making decisions from other mindsets. Yeah, they often assume that the safety's a gimme, like the safety's there anyway, and I can make choices that make me feel empowered, but still keep the safety. But it doesn't really work that way. The safety, the major safety interventions have been developed over, 100 years of obstetric theory, of applying a scientific model to the birthing process, and it's got a lot safer because we do those things. Not by magic. I'm interested too in that if 1 in 3 women in Australia are reporting that they've had a traumatic birth. I don't think there'd be lots of things that would be highly traumatic, but right up there is a postpartum hemorrhage.
I would say that would be quite traumatic.
Yes, and significantly more traumatic than having a needle in your thigh to prevent that postpartum hemorrhage the minute the baby's front shoulder is out. So I guess that's why we're here, isn't it? This is what the podcast is for, because what I've found across my career is that if someone says, "Oh, no, thank you, I don't want intervention X, Y, Z," often it's for lack of explanation. And if we take some time and explain why that intervention exists, well, sometimes people say, "Oh, well, that's different. I didn't know that. Now that you've explained it, thank you, I'll have it." And sometimes people say, "Thank you for explaining it. I still don't want it."
I still don't want it.
Yeah, and that's okay too.
Yeah. At least they've made a decision from being informed.
Yes, not from being, well, ideally they make the decision from a place of education and information, not from fear and distrust. Yeah.
Guess what? We've got a male caller. Ready?
Stop it.
We do. We want more male callers.
Hi, Dr. Pat and Brigid. My wife and I have been following your podcast throughout our pregnancy journey. I just have a follow-up question from one we asked a few podcasts ago. We unfortunately had an ectopic pregnancy managed with a single dose of methotrexate. We have been treated in the public system and discharged at the beginning of May with a HCG level of 2. My question relates to conception and the role of folate supplements and restarting them. Clinic we were treated in unfortunately gave us no guidance on this, and our GP couldn't really answer it either. We were told to wait 3 months post methotrexate till attempting to conceive again, which will be the 14th of July. My wife will ovulate on the 6th or 7th of July, which would be about a week earlier than this. We are really keen to start a family, but want to know what the implications could be for conceiving just before the 3-month window. And we're keen to get your thoughts on when we should start taking the Elevate prenatals again to boost the potentially depleted folate, and what interaction, if any, this will have with methotrexate given on the 14th of April this year. I know you can't give personal advice, but your thoughts on starting up folate and conceiving again would be much appreciated. There's not a lot of info out there, and we'll be first-time parents. We're not sure if it's safer to wait or we're just being paranoid. Thanks for your help.
Now, we've missed his window. It'll be interesting because it's now a bit past their date.
We're recording this in July.
A week later. But I thought it would be interesting for others to know. I didn't know that about waiting 3 months after methotrexate.
Yeah, so just to make sure everyone understands, firstly, I'm sorry to hear your bad news. So the ectopic pregnancy is a form of pregnancy loss, and I'm sorry to hear that happened to you. With increased use of ultrasound, we're getting very good at finding ectopics before they rupture. So someone's got a high pregnancy level. They come in for a scan expecting to see pregnancy inside the uterus with a little heartbeat visible, and none of that's there, and the uterus looks empty. But out in one of the fallopian tubes, you can see the start of an ectopic pregnancy, and a good scanner can pick that up. So because it hasn't actually ruptured, there's no need to rush around operating theatre and put in a telescope and take the tube out. It's possible to treat that with a drug called methotrexate, which is a bit like a chemotherapy type drug. It will destroy rapidly multiplying cells. And there aren't any rapidly multiplying cells in our whole body quite like the pregnancy cells. And so it almost selectively gets rid of those and leaves the rest of the body largely untouched. The dose is calculated based on the woman's size and injected, and it can destroy the pregnancy tissue in the tube. It doesn't really leave the tube undamaged. The tube is often blocked from that point onwards. But so its benefit is that you don't need an operation. That's the good news about it. The way that it works as a drug is it interferes with folic acid or folate metabolism very powerfully, and that's the way it stops the cells turning over. But it hangs around in your system for a while, and when you are pregnant, you want really high levels of folate. To avoid neural tube defects. We've discussed those elsewhere, spina bifida and anencephaly. So we certainly don't want any residual methotrexate affecting the folate that we take in the folate supplement, the ability of that to prevent those diseases. So the recommendation is 3 months, and I would take every day of the 3 months, but no longer. Yeah. So for the sake of a month, just let the 3 months expire, get pregnant again after that, and be confident that a standard dose of folate would be fine.
Yeah.
Also, you can start the folate whenever you like. It's not like it's not like there's any important reason not to be on it. It just doesn't work as well.
Right. Yeah, and if it helps to be in that mindset that you're taking a folate because you're preparing for a baby, then
get back in the habit.
Yeah.
But I wouldn't actually conceive until the 3 months were up.
Yeah. Great. Okay. I did not know that. And I didn't know. So, you say that the tube gets blocked. Can it be unblocked with a flushing?
No, not really. So it's always tempting to think that methotrexate might work a bit like Drano and sort of clean the tube out, like cleaning out a blocked drain, and then bingo, the pregnancy's gone, the ectopic pregnancy's gone, and we're good to go. But having had the ectopic pregnancy inside the tube will often cause permanent scarring. And even if you use methotrexate to end the pregnancy, it doesn't mean the tube's going to be necessarily functional. So it's more about avoiding the surgery than it is saving the tube. And in the next pregnancy, because there's been one ectopic, in particular, the fact that the tube that had the ectopic is still there, you can get another ectopic in that tube related to the scarring that's now there. So the next pregnancy needs to be watched very closely, and nice early scan to make sure that the pregnancy is in the uterus where it belongs. And do that nice and early again before it has a chance to rupture.
Yeah. So they would be monitored more now.
Yeah.
Yeah. And they're in the public system, so how easy is it for them to be monitored more?
Well, what we would do in this situation is not really rely on big, busy hospital to do this, because that sort of thing can get a bit lost. I'd be recommending that the minute there was a positive pregnancy test, we went through GP or obstetrician, organise an ultrasound, and have that ultrasound at 6 weeks, which would be late enough to show a pregnancy in the uterus, but not so late that if the ectopic was there, it had ruptured. Yeah.
It may not be the case with all obstetricians, but we do antenatal care, which means only. So, that one of our obstetricians isn't at the birth but can help do the antenatal care before the birth, and then the person goes off and has the birth in the public hospital.
Yeah.
It's like a shared care situation. So when you mentioned that you could go off and see an obstetrician, you can always see an obstetrician privately, but not end up birthing with them. So
yes, you can. It's not an option people often do, but certainly that is possible.
Yeah.
Not everywhere and everybody would offer that service. But the scan's a scan. Just the GP can organise it.
Yep, that's right. Great. All right. Well, we did get to a few more, not as many as we thought we'd get to in this episode, so we might have to do another Q&A.
Well, they were meaty questions.
Meaty questions. Yeah. They were good questions. Thank you, people.
It was nice to hear a male voice.
Yeah.
On the.
It must have been his partner that called in if they said it was a follow up.
Yes, because we haven't heard him before.
No. So that's great. Excellent. I love it that there's this to and fro with some people. We're getting second time callers.
Yeah,
it's great.
Let us know when you've got some happy news then at next pregnancy.
Next pregnancy, exactly. All right, everyone. Well, thank you for listening. And as I always say, if you love our content, please share it with a friend. They can be as informed as you then. And until next week, keep listening, keep growing those babies.
Thanks for listening, everybody.
Bye for now. Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.